Now, the recommendation for screening for ovarian and endometrial cancer, if somebody is asked, what do you do for ovarian and endometrial cancer screening? The answer is no screening is effective. No screening test is effective for detecting ovarian endometrial cancer in the asymptomatic population. But in high-risk population, it is slightly different. For ovarian cancer syndromes like BRCA1, BRCA2 mutations, HNPCC, you can do an annual rectovaginal pelvic examinations along with TA125 testing and transvaginal ultrasound. So this is the recommended investigation that we're talking about. So until childbearing is completed or until at least 35 years, at which point of time you can consider doing a prophylactic risk reducing bilateral oophorectomy. So these ovarian cancer syndromes until 35 years or whenever the childbearing is completed, till the time you have to screen, you can use these the annual testing with physical examination, CA125 and the transvaginal ultrasound. For endometrial cancer, recommendation is to do an annual endometrial biopsy to evaluate the endometrial histology starting from the age of 35 years. Next slide, please. Now, with regards to lung cancer is not a very good cancer to do a screening. The reason why I say this is because it is a disease where unless you pick it up early, if you pick up a late disease, then it may not transfer into a much of a survival advantage. And number two, the lead time bias that you get in cancers like screening that we have for a cancer cervix or what we have for a colorectal cancer may not be there in a lung cancer. But the fact that it is a very killer disease means that if you use a low dose CT, that is 8 millisieverts, and in patients who are high risk, who is a high risk patient? Anybody who has a history of 20 pack years of smoking, starting from the age of 50, or advised for current smokers or ex-smokers since 15 years. So these sort of high risk population, if you use this low dose CT screening, then it may be a very efficient tool. Next slide, please. So what is the evidence and what are we talking about? The National Lung Screening Trial said that this low-dose computerized tomography, low-dose CT, can perform a lung scan in 15 seconds, okay? And it is advised in the age group of 55 to 74, at least 30 pack year smoking history, currently smoker or smokers who have quit within the past 15 years, they have to be in relatively good health. These people, this US Preventive Task Force has given a grade B recommendation. Yes, there is a moderate benefit of doing screening in this subset of population. So any smoker comes, you don't say a lung cancer screening, go get a CT done. No, it's not going to be useful. So it has to be in this age group of 55 to 70. Patient already should be in very good general good condition. They must have had a 30-year pack year smoking history, currently smoking or quit within the past 15 years. So these are the screening criteria where you can do this low dose CT. Next slide, please. So what do we do with regards to prostate cancer screening? Normal risk asymptomatic subjects. Prostate screening is done with a PSA testing. Serum PSA is a blood test. What we do, we start at the age of 50 years after talking to the patient, the pros and cons of this testing. And especially so in a high risk population like African American or who has a relative, father or a brother with prostate cancer below 65, men should have this starting at 45. So most individuals it's age 50, but this sort of a high risk individual like African American or with family history of prostate cancer, then you start at 45. So this is when you will do this serum PSA. Digital rectal examination can be combined with PSA, but it is not a very useful tool and you cannot have any individual recommendation for it. So this is with regards to prostate cancer screening. Next slide, please. Okay, so there are some risk reducing cancer surgeries are there, okay? You cannot exactly call them as primary prevention or screening, but there are some cancer reduction, risk reduction surgeries, for example, in ovary, breast, uterus, colorectal, medullary cancers and diffuse gastric cancers, where by doing these procedures prophylactically, you can bring down the risk of cancers. Next slide. So this risk reducing salpingo-oophorectomy for BRCA1 positive patients, where you can do it before 35 or around 35. there is a risk of cancer reduction in ovary by about 96%. It reduces the ovarian, tubal and peritoneal cancer risk by 80%, and breast cancer risk is also reduced by 50%. Keep in mind though that by doing the risk reducing salpingo-oophorectomy, they can still develop the primary peritoneal cancers, and so this has to be kept in mind for BRCA positive patients. So don't say that they will not develop any cancers. The risk is going to be lower, but primary peritoneal cancer risk will always be there. Concomitant risk reducing salpingo-oophorectomy with hysterectomy can be combined with HNPCC tumors for reducing the risk of both ovarian and endometrial cancers. Next slide, please. You have the option of doing a total proctocolectomy or a total colectomy with ileorectal anastomosis for familial adenomatous polyposis patients. You can do an endoscopic surveillance of the remaining rectal segment at about 6 to 12 months interval. So these are surgical prophylactic procedures done to prevent development of a cancer. Next slide. In hereditary diffuse gastric cancer families before the age of 40 years, or in patients with CDH1 mutation which is proven, okay, there you can do a prophylactic total gastrectomy. The consensus recommendation is to do at the age of 20. Okay, this reduces the risk of developing a primary hereditary diffuse gastric cancer. It is a very highly killer disease unless you pick it up early. And that is the reason why by doing this prophylactic surgery, the risk of diffuse gastric cancer can be eliminated. Next slide, please. In MEN syndrome, the multiple endocrine neoplastic syndrome type 2B, then we recommend a total thyroidectomy with level 6 neck dissection in less than 1 year of age. Whereas in MEN 2A and the familial medullary cancers, we recommend only doing a total thyroidectomy at the age group of 5 to 6 years. So you have these prophylactic surgeries in certain syndromes like MEN syndrome. So these have to be kept in mind. Next slide, please. So with this, I have completed the discussion on screening for cancers, what test can be done, which cancers can you screen, how to select a cancer for screening, how do you screen, and what is the risk of doing the screening test, and how much is the mortality reduction benefit that you see, and also about certain surgical procedures as risk reducing procedures in cancers.